Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with severe otalgia. So otalgia is a medical name for an earache, reduced hearing, pressure in the ear, and they've been getting a lot of discharge, otorrhea, which is all this white gunk here. And they have been symptomatic for around 5 years. It's been a chronic ear infection and it's been intermittent, but they decided finally to have someone examine and treat their ear. So the condition they have is called otitis externa. Otitis externa is an umbrella term for an ear infection of the outer ear. And the term otitis means ear infection and externa is a location. You can also suffer from otitis media. So otitis media is an infection of the middle ear, for example. Now, we can't yet see the eardrum. We've got all this discharge and dead skin, and it's actually coating the patient's eardrum. And you may have seen that as I was peeling this dead skin and discharge off the eardrum itself was flexing. And you might even see that again. So we're just going to be very careful here. I suspect this patient previously, because this infection has been chronic for about 5 years, that they may have suffered from a tympanic perforation, so perforation of the eardrum. So a perforation of the eardrum is essentially a hole in the eardrum, and I think it's healed. And when you have a perforation that's healed, it becomes very thin. It becomes very hypermobile, very hypercompliant, and therefore you could be a lot more careful when you're suctioning on the eardrum because there's a potential of perforating that eardrum again because the eardrum's weakened. So the eardrum is made up of three membranes. The most outer membrane that's facing towards us, we call that the lateral membrane, and that is made up of the same skin that lines the inner two-thirds of the ear canal, which is a very thin layer of skin. Again, you may have seen there the eardrum flexing a bit. So the eardrum is now fully visible. Now, which I will come back to the structure of the eardrum in a moment. Now, the main area of concern whenever I've got a patient is what we call the posterior superior quadrant, which in the case of the right ear, this is the patient's right ear, it's northwest. So northwest, so it's probably to the left of where the sucker is now, where I just a bit higher up than I am now. And I'm going to go back to this area and just clean it up. That's where a cholesteatoma can form. And a cholesteatoma, if untreated, can be life-threatening, and it's a collection of dead skin. You can see this patient's got a lot of dead skin that forms into a plug in the northwest region of the eardrum. If it was the left ear, that would be the northeast. And that's because in the northwest region of the right ear, the eardrum can be retracted, the eardrum can get sucked in, and it creates a pocket. It creates a little bay, and dead skin can accumulate and form in this pocket. And it can enlarge, and then it can grow, then it can extend into the middle ear and up towards the brain, causing a brain abscess potentially, meningitis. So I just want to clear that. You can see there's a white layer of skin there, and we're going to, because I don't know what's underneath that, it may well be there's a cholesteatoma. So there wasn't, fortunately, but we don't know that at the moment. So what you're going to see me is just continue peeling away as much as dead skin as I can. We've got to be careful because the patient did attend with an earache, so their ear is very tender. You can see why. It's very swollen in there. They've got loads of granulation tissue, so all these red bumps and lumps, that's what we call granulation tissue. So granulation tissue occurs as part of the healing process when there's trauma or an infection, not only in the ear but in other parts of the body. And granulation tissue is a buildup of connective tissue that then has its own internal blood supply, and it gives this bumpy red appearance. And the patient's got an abundance of granulation tissue. So what we're doing today, we're just vacuuming the ear. We're cleaning out as much debris and dead skin as we possibly can without causing any additional earache for the patient. But of course, we refer them to their doctor. They're going to need some antibiotic treatment for this. So I'll just go back to the structure of the eardrum. So the eardrum is made up of three membranes, and the outermost lateral membrane that's facing towards us, it's made of the same skin that lines the inner two-thirds of the ear canal. So it's a very thin layer. The middle layer of the eardrum is made up of fibrous and connective tissue, and that's what gives the eardrum its kind of strength and rigidity. And the inner layer that's facing the middle ear, that's the mucosa. So the mucosa is the same skin that lines the middle ear. It's like the same skin that in our nose, for example. It's a secretory membrane. It can secrete mucus. It's more of a wetter layer. And when you have a perforation, all three membranes are pierced, they're punctured, they're breached. And when a perforation, if it does heal, so the younger you are, typically you're more likely for the perforation to heal. It can take up to 6 weeks. The outermost and the innermost membranes have got the ability to re-heal, but typically the middle membrane doesn't. And that creates a thinning of the eardrum, because instead of three layers, it's 2 layers. And when you've got a healed perforated eardrum, that area of the eardrum is naturally weakened now, so you just got to be a bit more careful and gentle. Now I'm just using the fine end suction probe. I've just made a little bend, a little kink in it. It just gives me a bit more flexibility and orientation in the ear. And again, I'm just trying to peel layer by layer of skin away. So in terms of the patient's hearing, they can hear significantly better already. But whilst the patient's here, again, I just want to get as much of this infected dead skin away. So that there is granulation tissue, it's quite a big piece, the red bit at 6 o'clock at the bottom of the screen. Sometimes with granulation tissue, if it doesn't respond to antibiotic treatment, ENT surgeons cauterize it. I think they use silver nitrite, and they just basically burn the connective tissue, and they hope that when that then re-heals, the connective tissue doesn't form. Again, you've got loads of connective tissue here. So it's not a very happy ear, it's quite traumatized. You can just see how clear the view is with our eye clear scope. So behind this granulation tissue, you've got this thickened layer of skin, and that's where the kink in the suction tube really helps. We can get almost in and behind that granulation tissue. But their hearings, the patient could hear significantly better even at this stage. For the next for the next 10-11 minutes, it's just literally me just being just as meticulous as I can and peeling away as much of this debris and skin as possible. You can probably see that kink there. So we're at the roof of the ear canal here. Now, this is the region that I really want to just clear, because we don't know what's behind this. A bit more to the left, if I'm honest, but even this region, we just want to know, is there something sinister lurking behind the skin? Is the skin hiding that cholesteatoma? I do remember it was difficult. This is the region that we want to, this is the region of concern and of main interest, and it was very difficult to get access. If I'm correct, I just asked the patient to tilt their head over towards their left shoulder, and I came off my ENT stool and I was almost on my knees looking up and into the ear to get access here. So the skin's quite adhesive, it's very sticky, it's not coming away without a fight. But now we can see that posterior, we can see the northwest really clearly. There is no cholesteatoma, so I'm really pleased with that. There is a bit of skin in that region still, but it's not where a cholesteatoma would form, so I'm very content that there's no underlying cholesteatoma. So we're just in the anterior recess now, so this is at the front of the eardrum. There's like a little alcove, a hidden cave there. So we've got a nice piece of skin that we managed to peel away. So you can really see the whole eardrum now. So now we're on the anterior canal walls. This is the front part of the ear canal. It's on the bony portion, but everything's just swollen. You've got so much connective tissue here. But again, sometimes you can also run the risk of having a canal cholesteatoma. So a traditional cholesteatoma forms in the pocket in the northwest region, but sometimes skin can ingress within the ear canal itself, and it can form an infected skin plug that can then chew away at the bone, the temporal bone that forms the ear canal. and it can potentially then spread to the mastoid bone, which is the bone behind the ear, and to the jawbone, and it can lead to Bell's palsy, so partial facial paralysis. So we're just going to be careful as well. This patient hasn't got a canal Cholesteatoma. They are quite rare, but I have come across quite a few actually in clinic over the last few years, and fortunately we've managed to. I know there's a very avid viewer, very big fan that watches all of my videos. That I think it was in January that I think it was in their right ear as well. I had suspicions of a canal Cholesteatoma after performing ear cleaning, and we've got them referred, and they had a CT scan and it was, and they've had surgery, so it'd be interesting to see what the condition of the ear is like next time they attend. So just in that region, you may have seen it's like a little dip there, but it's hard to know. I mean, in a canal Cholesteatoma, it would form a little erosion at the base of the ear canal. Now, potentially that might have been a bit of a canal Cholesteatoma that just removed, but there's so much swelling there, so much granulation tissue, that itself can create that effect. You may see where I just removed that, there's like a little dip. So it's very important when we've written to the doctor that once they've had their course of antibiotics and everything's settled in the ear, that they have to have the ear re-examined just to make sure there's nothing else going on at the base of the ear canal, just in this region. So I was slightly concerned that might be a bit of a potential canal Cholesteatoma. So you can see that granulation tissue to the right, it's very spongy. It's just like a piece of flesh, it really is, and you may also be able to see all the blood vessels that's supplying that. You know, I'm just going behind that just to peel some of the skin off if I can, but it's very tough, this skin. So we're right next to the eardrum, so what you're seeing directly behind the suction tube is the eardrum. Just to the left of the sucker is the hammer bone. It's not very, the landmark's not very distinctive in this patient's eardrum. So it's just that bottom region there, 6 o'clock, where I'm zooming in now. That's a possible area where we may need to be slightly concerned. But again, as mentioned, we'll get the patient's ear treated, so all the swelling, granulation tissue goes, and then we can re-examine. We'll rest of the patient's more than welcome to come back. But in a sense, we've referred him to the GP now, and if that's the case, we'll need to do an onwards referral to ENT. So again, it's just going to spend the next 4 or 5 minutes of the video, just mopping up all around the edge as much as we can. So the key critical thing for the patient is to avoid water entering the ear. If they get water in the ear, it will just only exacerbate this and worsen it. So the patient's aware of that. They're going to avoid any water, so when they're showering or swimming, for example. As you can see, it's quite nasty. The bottom, the southern hemisphere, if you like to call it, of the ear, it's really loads of granulation tissue here. And there is some potential widening of the ear canal. So when you've got an infection for about 5 years, this dead skin and bacteria and debris, it can start chewing away at some of the bone and widen it, not only at the base, but also here posteriorly. And this is towards the mastoid bone now. So again, we definitely need to have their ears re-examined after they've had their treatment. So at the moment, I've got the endoscope. It's just holding it freestyle in my non-dominant hand. I've not rested because it's not actually in the ear. It's on the outside part of the ear, the endoscope. So I've just got to keep my left hand really, really steady because it's not being supported by anything at the moment. When you work laterally of the ear, quite often there's nothing really supporting the endoscope. You just have to hold it as still as possible with your non-dominant hand. When you're further into the ear, then yeah, you can start resting it slightly against the cartilaginous portion of the ear canal. So we're very lateral, near the entrance, just peeling away some of this it's very thick layers of epithelial skin, so at the outer layer of skin. We've got some crusted skin here. It's a bit difficult to remove this thing. If I remember correctly, the patient found us slightly a bit uncomfortable, this region of the ear. So I got peeled away as much as I could. I think I had to come out the ear in a moment because it blocked the suction tube. I think they got a bit of blistering here. You'll probably see in a moment when I lift the skin away, it caused a bit of blistering and just I wouldn't say the ear was bleeding, but you can see a bit of blood just peering through and it didn't need to be stemmed, it just settled on its own accord. I think it was here. The skin it's really crusted when you lift it away. I think you'll see it in a moment. I think it's this region. You can see to the left you're getting a bit of blistering. Just there. So if you watch it back, we didn't actually make any contact with this particular region, but it's just because the skin's so tightly adhered. And because it's inflamed as well, when you peel it away, it's just a bit of blood comes through. Call that kind of contact bleeding. I think the sucker's blocked, so it's going to come back out and just unblock that. So you can see the difference to when we began and where we are now. So yeah, it still doesn't look very happy, the ear, but we're in a lot better place. The patient can certainly hear tons better. We're just got to get this infection treated safely. Patients got to avoid poking in their ears and getting water in their ears. So I think I'm just going to go back for that piece of skin there if I can. You can see the angle's very difficult, so I've just I've just twisted the fine end so that the kink goes upwards. I think I managed to get it, I'm not sure. There we are. So I might not get all of it, but I'm certainly got a big bulk out there. Just going to a good examination of the eardrum just to make sure I've not missed anything that's potentially dangerous, which I haven't. Just looking at the back part of the ear canal, so again it could be slightly eroded here. So I hope you enjoyed that video, guys. I hope you're all keeping well and safe. Do stay tuned. I've got loads more videos to upload in the next few days and weeks. Take care and speak soon. Bye.